Good afternoon, and thank you for joining today's webinar. We're talking about an exciting topic, hopefully more exciting than the football match that's going on, and because of that, we'll give you the score of the USA-Germany match by the end of the webinar. But my name is John Cassell. I'm the Senior Partner at Spring Consulting Group. Spring is an actuarial consulting firm that works with both employers and providers in the area of employee benefits and risk management. We're a bit of a pioneer in the captive space. We worked on some of the earliest employee benefits programs put into captives in the early 90s, and we've been involved ever since. I'm pleased to announce that I have two panelists with me that are joining me giving this presentation. Tracy Hassett, who's the Vice President of Human Resources at Worcester Polytechnic Institute. We're very pleased to have her here today. And Terry Weber, who is a fellow partner at Spring Consulting Group. Just a few housekeeping points to let you know what's going on. We will mute microphones so that avoiding any background noise. If you have any questions directly, please add them to the box that you see on your screen. If you want to send a private message, you can send a message to the presenter using the chat box. We will record this program, and copies will be available to attendees. Just turning to the agenda, we've designed the agenda to describe the advantages of using captives generally, and then demonstrating how they can work very well for groups of schools and colleges. So we're going to give a little bit of background about U.S. healthcare and the environment that we see ourselves in around the ACA. We're going to talk about how you can use captives to stabilize and manage health insurance costs. We're going to look at multi-employer captives and their application to schools and colleges, look at those in a bit more detail. And then Tracy is going to talk about a case history, the Ed Health Group captive for schools and colleges. We're then going to touch a little bit on future developments and then how you can learn more about the program. So let's kick off by talking about the current environment. As you're aware, our healthcare system has had a long history of basically inefficiency and also inequality. The U.S. currently and has for some time spent more per capita on healthcare than any other country in the world. And yet it's often behind in terms of health outcomes. And this has been a problem that a number of governments have tried to address and tried to change the paradigm as far as health in the U.S. is concerned. The latest version, which is the Accountable Care Act, implemented by the Obama administration, has resulted in a very strong attempt to change the incentives and the structure of the health system in a very broad way. And the necessary result of that is there's been a significant increase in complexity and uncertainty for employers who are having to manage the health care of their employees in an effective way. Just in parallel with that, individuals are being forced to make important health care decisions with really few tools to help them. That transfer of responsibilities has been going on for some time, and it has major implications for making the wrong choices in complex medical situations. And so there's definitely a gap there in terms of enabling people to make informed choices about healthcare. Another critical issue is that new taxes and penalties are very difficult to track and change from year to year. We see a lot of inquiries from our clients about exactly what various taxes mean and what the implications are for them. Interestingly enough, we were talking to the CMS yesterday, that's the Center for Medicare and Medicaid Services, about the implementation of a certain tax. And even at this stage, they could only describe the timetable for developing the process for how the implementation is taking place. So a lot of things are in flux and is causing a lot of problems for employers coping with this. As a backdrop, we see shrinking workforces as the economy has tightened up the number of employed people in the U.S., and the aging of the workforce has made health and productivity a very critical issue. They are in fact factors that we've been dealing with for some time, but it particularly affects healthcare and healthcare provision to those groups. So let's talk about what individual schools are facing. As we've said, schools, and particularly their HR departments, are really dealing with the fact that a lot of insurers are passing additional ACA costs directly onto the schools, and if they are involved with fully insured contracts, they have very little control over that. Small and medium-sized schools are being asked to be as familiar and compliant as their larger compatriots with the new healthcare laws, and therefore an organization that might have 2 or 3 people working in their HR department are expected to perform like somebody who has 15 or 20 people involved in this area. And this has put a lot of pressure on small organizations. Schools with fully insured plans are being asked to pay more taxes than those with self-insured plans. This is a consequence of the new taxation that is coming in. So the health insurance industry fee, which can vary from somewhere around 2% currently to over 4% in the future, is being paid by fully insured contracts, but not self-insured contracts. So there's immediately a differential there that are causing people that have fully insured contracts to reconsider whether they want to continue on that basis. We see that typically in order to manage cost escalation, the cost of health insurance, in increasing proportion, is being passed to employees, and the structure of the benefits are such that out-of-pocket expenses are increasing. So you start to reach a position, if you're using only these 2 mechanisms, that individual employees are questioning the benefit of their health insurance plans and also questioning their ability to pay the out-of-pocket expenses. There's significant change, and many brokers and consultants who are maybe only partially involved in health insurance are often ill-equipped to advise their clients, and typically schools and colleges lean heavily on their local brokers to provide information. And basically, you are finding that, or certainly we're finding that there's a lot of misinformation out there that people are having to wade through to get to the facts of the matter. We see in a lot of cases that healthcare cost inflation has been outstripping the ability of schools to even raise tuition fees, and there are examples where the entire value of the tuition fee increases have been taken up by higher health insurance costs. And this is a very significant issue when tuition fees are coming under a lot of scrutiny. So what are people doing about it? One of the routes that employers are taking is to look at group purchasing solutions. So employers are banding together to buy their health insurance and other employee benefits as a group and as a way of controlling this type of exposure. This doesn't mean that they necessarily have less choice in their health plans, but they do have an opportunity to manage cost increases and, just as importantly, manage cost fluctuation. Overall, in this type of structure, employers can transparently manage their costs, and that's very important. Certainly, traditional health insurance feels like a drain in which you stuff money and you're not quite sure of what the benefit you're getting out of it. In the type of structure that we're talking about here, there's a great deal of transparency, and you can see where every dollar is being spent. And if the group starts to buy as a group more efficiently, then as the group increases, the program spreads its cost base over a wider population, and it becomes more efficient. Many schools and colleges are part of existing consortia and other collaborative programs that can form a platform for managing healthcare costs. And Tracy will talk later on about how that particularly works within the health structure. So what are the benefits we're talking about? We see that groups of schools working together can self-insure their healthcare risks at lower cost. Many schools worry about moving from full insurance to self-insurance, but within the type of structure we're talking about, there's some more safety around being able to do that by the way in which risk is pooled, and we'll talk about that more later. There's the opportunity to bulk purchase administration and medical management, and most importantly, besides creating economies, the administration services and the medical management services can be focused on the particular population. So if you have a group of schools with similar structures, then you don't waste resources on things that aren't relevant to that group. It's possible to offer a wider range of health plans, and you can provide, again, like medical management and administration, you can provide wellness programs that are tailored to the specific group's requirements. Again, it's efficient and economic. So why consider in this structure using a captive insurance program? So employers have successfully used captives on the property and casualty side for many years. They cover things like medical malpractice, workers' compensation, and other general insurance risks. And organizations have used this structure going back to the early 30s, and 60 to 70% of the Fortune 500 use this structure. Captives have been used by employers to fund employee benefits since the mid-90s, and we've been structuring and setting up programs like this from this time. And many well-known employers use this form of funding, from Intel to Coca-Cola to Microsoft. Again, we've described that captives provide a completely transparent risk management process where every dollar invested is clearly accounted for. So if there are contingencies made for additional risks, or there are charges placed in the P&L for the program, if these monies are not spent, then the benefit is accrued to the group involved, and it's not lost to a third party, such as an insurance company. They provide stable and long-term savings for benefit programs, and often within the structure you can retain existing carrier relationships and plan designs. If, for example, you're using Cigna for your health insurance, then funding the program through a captive need not change anything that the employee sees. Basically, as far as the employee is concerned, it stays the same. It's simply the funding mechanism in the back that becomes more efficient. So why should schools consider using a captive? We've been able to demonstrate reduced benefit costs and stable price fluctuations over the long term. A lot of our clients are interested as much in creating price stability as savings, and that's a benefit that we can offer through these types of programs. You can control benefit program designs and change them as your needs evolve, so they can be very customized. You can manage the level of risk that's taken within the structure, and for catastrophic risks, you can buy reinsurance separately in the market, but as the group grows, the need for reinsurance can decline. As we've said before, you can customize health management programs, and you can run data on the group so that you understand the impact of those health management programs and tune them appropriately. Savings that are generated through the funding structure and through efficient health management can stay within the program and can be invested to securely provide returns to the participant. And in many cases, we can structure the program so that each participant is individually underwritten and therefore is protected from another school's bad experience. There's not the degree to which you are pooling your risk with a group of other schools that you feel may not be doing as well as you. Your effective program management accrues to you. So in summary, we're talking about a structure that exists at the moment that in a particular area, you would see a number of colleges and schools effectively working independently, often using the same provider. So a health plan provider might be working with 2 or 3 colleges and really only offering them rates that reflect their population and their size rather than as a group. So there's a great deal of inefficiency there, and particularly smaller schools and colleges find that causes their cost to increase significantly and be high in the first place. So what we're talking about in the new landscape is really to structure a captive program into which a number of colleges invest and run, effectively having their own little insurance plan, and therefore, as a group, selecting appropriate health plan providers, wellness providers, pharmacy, employee assistance programs, these types of programs that can be purchased efficiently by the group as a whole. The decisions can be made locally, and basically the costs can be driven out of the system by that structure and efficiency. So that's basically the approach that we have here, and we think that it works very well within the college setting. So I'm going to ask Terry Weber, my colleague, to talk about this in a bit more detail.
Hi, everyone. This is Terry. Thank you, John, for that introduction. I'm really going to build on the core concepts that John developed over the last few slides and hopefully give a little more insight on the group captive structure itself so that when Tracy picks it up, she'll be able to give you some clear examples of how the Health program works. Generally speaking, the group captive structure really embraces the core concepts of insurance. So it really builds on group purchasing, the law of large numbers, to really bring groups together that have some commonality. And the way that it functions is really to allow groups that are fully insured or potentially self-insured to take out some of the waste in their current structure. So there are more efficient funding vehicles that allow for savings. But in addition to cost savings, which is obviously important for all of us, it also gives you a little bit more control. And we'll definitely be talking about that in the slides that follow. But, some things that allow for more control is really just to design the program the way you want it to operate. And some organizations, whether because of risk tolerance or because of their size or because of how it's structured, really either feel like they don't have control or truly don't have control to make independent decisions. And they're really at, really need to depend on their vendor and carrier partners to give them guidance. But this type of structure really allows smaller organizations to band together using the fundamentals of insurance to make a more cost-effective and stronger program for them overall. And I think one thing to highlight on this slide is that the benchmarking and the best-in-class processes and practices that some large employers have been leveraging for years are now really able to be in smaller employers' hands and specifically at institutions as well. Now, when we look at the structure and how really it develops, one of the important things is to make sure that the captive and its membership grows over time. So as John was really talking about the core structure of a group captive, if you're a visual person, that's kind of the center of this visual, center of that core of the group captive. And that's really where the short-term implementation exists. That's where groups come together. That's where groups determine feasibility. They determine plan design, process, technology. They really put it all in this core unit. And we're going to talk about that core and all those decisions in more detail. But from there, the ultimate long-term strategy is to then grow. So to take that core basic foundation and to build on it, get some early adopters, which you see there in kind of that green section, and pull some members together. And then once it's really more established, to build and bring on secondary adapters and adopters. So people that can adapt the program to their needs and then also adopt what's been created by other folks in the program. And I think it's important to have members at varying levels, people that come in at the beginning and are able to really lay the foundation and really start to make those important decisions of how the group will be structured. And getting in early definitely gives you more control over that. But of course, there's always going to be people that don't want to jump into a solution, and so setting a structure that allows them to join later is definitely best for the entire group. Now, when we're talking about a group captive, or in some cases an association captive, what's really important is that this is a bit different from traditional, what we would call single parent or pure captives. And if you're someone that doesn't know the captive market, that's fine. Really, all that is a captive that's owned by one entity. For these types of group captives, or potentially an association captive, what it really allows is groups to come together. And that group does not have to agree on all of the tenets. So they can have different risk appetites. They can have different plan designs. They can have different goals. As long as they can come together and create some commonality in terms of medical plan design and medical process. And so you'll see here that the basic components to this group captive structure is to provide self-insured plans for each group with stop loss for each employer. And that, of course, is regulated through the captive insurance industry, and a domicile is selected to help to manage that. And what it really allows each institution to do is to purchase their own medical stop loss, have access to the reinsurance market directly, and in addition to use the captive itself for also some stop loss and reinsurance. And at the end of the day, it really allows for tax savings as well as efficiency, and it also gives stronger ties to the carriers. Obviously, we all understand that at the core, the more bodies we can throw into a program, the more aggressive carriers can be. And that same concept really works here. One thing that's important to note in this structure, I tried to articulate it earlier, is that each school doesn't have to have the same risk appetite or each entity coming together. They can have different self-insured retention levels, and we'll talk about that, and I have a visual about that in a couple slides. And although there needs to be some commonality in benefit plan design, there can also be some differences, and Tracy will definitely talk about that towards the end of the presentation as well. So if you haven't been paying attention in the last few slides, this kind of is a recap of some of the key things to talk about. Why pool the experience together? Really, it's to highlight the concepts, the law of large numbers, leverage insurance. The more people that you can get into a group, the more predictable and credible the experience becomes. So those high-cost claimants that made you very nervous to potentially self-insure on your own now become less difficult to manage, less scary if you were to have one early in the year. Definitely coming together allows you to get better discounts, better pricing concessions, more customizable plan designs, which can be important. And it also gives you, as I said at the beginning, more control. And a big part of that control comes from self-insurance. Once you're self-insured, you can pool risk, you can determine your plan design, and you are also able to avoid some of the taxes that are in the fully insured landscape. One thing that we used to talk a lot about is investment income. That certainly isn't a big sales pitch any longer with investment interest rates where they are, but still keeping that money within your own or your shared captive is certainly much better than giving it to another company to add to their profit line. So even if those investment margins are small, that's still another way for you to benefit as well. So when you think about why a captive, why move to this structure, why do I want to pool experience, it's really to allow smaller, mid-sized organizations to be treated like a larger institution. You'll have direct access to the reinsurance market and really be able to reduce some of the restrictions that you had before. So one of the interesting questions we get a lot is about domicile. Tracy will talk about this specific example being domiciled in Vermont, which is certainly a wonderful domicile to select, but there are many others. There's 30 plus states that have captive statutes, and those statutes continue to grow and evolve. And the law is definitely amenable to not only pure captives, which is owned by one entity, but also group captives, association captives. And if you're someone that wants to learn more about captives, we can definitely give you more insight on much more complex options as well. But really, the captive market has grown, and the infrastructure really is there to support it. And the only thing to consider really when you're talking about employee benefits is, generally speaking, there are some exceptions. You do need an onshore presence, so you need to have a captive that's within the U.S. But certainly beyond that, you can look to many different domiciles to meet your needs, depending on the structure you want, where you're located geographically, and where the partners are if you're in a group structure. So how does a typical structure work? You know, every structure is a little bit different, but when we're talking about healthcare, which we are talking about here today, what we're really trying to do is design something that works for all of the members. So if we're talking about a group captive structure with colleges and universities and bringing them together, you're going to need a core set of plan designs that will work. So we've listed here somewhere between 5 to 8 plan designs. It's not that you can't have more, it's just that the bigger and the more intense the program becomes, the less efficient, and in some times, the less savings that can be achieved. So the goal is really to eliminate any waste that's out there while still offering enough choice to the membership. And the way that really behind the scenes of the financials work is that each member institution is given rates very similar to how they're given them now. It's just instead of them being handed from an insurance company over to the members for them to negotiate or accept or reject, they're really developed throughout the year. People understand what's going on with their utilization, what's going on with their experience. So the rates reflect what's going on not only with their individual program, but also with the captive overall. And it's net of profit, you know, out to insurance companies, commissions out to brokers and consultants. So that's just a much more effective and efficient means in terms of getting your rates. The structure really allows you to self-insure. And I think that's an important distinction. I've talked to people sometimes and they say, oh, you're providing what the industry would call first dollar coverage. And it actually is not first dollar healthcare coverage. What this really is a mechanism for each entity to self-insure their healthcare and then find a way to reinsure their risks and pool together their risks above a certain retention level. And the next slide shows a visual on that. But before we go there, you know, a lot of this is managed very tightly by captive managers, by actuaries and consultants, and people that really do this day in and day out to make sure that the program is sound, to make sure the rates are sound, and to make sure that the management of the program, down to the nitty-gritty, what network will we use and how will claims be paid, you know, all those things are very important. I think to pause for a second, captives have been used for years and years for life insurance and disability insurance. I think the reason why medical plans took a little while to be adopted is because medical feels like such a personal decision. And so to have employers or associations or groups start to get involved in unique funding for their medical, I think was a little bit scary. But it's no longer that way. You know, there's no reason to be concerned. Medical decisions and medical funding doesn't change the fact that their employees can go to the same physician, that their employees can have their claims paid by a brand that they're used to. And, you know, in our captive that Tracy will talk about, we're using 2 premier Massachusetts-based companies in Harvard Pilgrim Healthcare and Tufts Health Plan. So that risk and that concern really is no longer a problem for folks. Just a few more slides before I pass things off to Tracy. These next 2 are for our visual learners out there. This really shows the same concept that I've been talking about over the last few minutes about how it's the concept is a self-insured retention level. So each member has their own risk pool, and that's displayed here in the blue. And then beyond that, there's pooling of risk. That's represented here in the green. So that's the captive. And the captive can help to pool risk on an aggregate basis or a specific basis. And for those of you that might not be in this in this area all the time. What that really ties to is specific risk is per claim risk. That's where you're worried about your high-cost claimants. Aggregate risk is really looking at your overall population. So if you expect to spend $1, but you spend $1.50, that's your aggregate risk. And so the captive can really cover both of those. Now, what's there in the orange, or depending on your screen, it might look gold, that's where we still tap into the reinsurance market. So we're always looking to make sure that the group has the risk appetite and that the program matches their risk tolerance. So those that have the ability to take on more risk can, and for those that can't, we can always find reinsurance partners as well. And when we talk about reinsurance partners and how much stop loss is required, that obviously changes depending on the size of the group. So this visual shows along the bottom there employee lives, and then along the y-axis the stop loss level. So as you're a bigger group, you obviously can have a higher stop loss level. And I think what's interesting here is we show the lives in green, and then, the employee lives there in blue. And I think really what it shows is that although both of these lines slope, it's not a perfect slope. There are going to be people that we see it there visually on the $100,000 stop loss level. There's groups that are smaller that would be willing to tolerate a $100,000 level, and groups that are much larger that still don't want to go higher. So you'll be able to customize this depending on the group and your group appetite. I want to turn things over to Tracy in just a minute. So this is an example of how the cost would work out, really just to show you how the fully insured premiums would relate to the program costs. And you'll see that the structure for this really is very similar to a fully insured program in that it's claim costs and administrative charges. What we really are able to pull out of this for savings is any profit that would go to an insurance company, taxes and fees, and then some more aggressive pricing that we're able to get through group purchasing. So in summary, the initial savings come from the pooling, the movement to self-insurance, but the long-term savings is where we can really start to bend the trend. And those come from getting the program together and targeting what's important to that group of people, whether it's health management, minimizing risk, benchmarking, setting best-in-class programs, whatever is most important to them. So Tracy, I'm going to kick things over to you to tell us a little more detail about this specific program.
Terry, and welcome everybody. My name is Tracy Hassett, and I am the Vice President of Human Resources at Worcester Polytechnic Institute, and also serve on the board of Ed Health, which is the health insurance captive that was formed just a year ago this upcoming Tuesday. And I'm going to talk to you from the perspective of one of the schools that took the leap and decided to go forward in this. So a little bit of history on why Ed Health was started. Back in 2009, several schools in Massachusetts began to talk about ways in which we could get together to make our health insurance more efficient, more cost-effective, and to really benefit the employee as well as the employer. As both Terry and John mentioned, as we've all seen over the years, health insurance has become very complex, very complicated, and very expensive. And we're all looking for ways to make it, to continue the quality of health insurance that we're offering to our employees, but to make it more affordable for both. So the multi-institution participation seems like the best idea for us, and what it really did is it allows this captive to take advantage of the large number of employees. It also gave us the opportunity to renegotiate administrative fees, and one of the biggest benefits that we have seen by starting the Ed Health captive was to provide disease management and wellness programs to all of the members who are included in Ed Health. So as I said, we have been live. It'll be 1 year on July 1st. We have 9 schools who are currently participating in Massachusetts and over 15,000 covered lives. We do have 3 more schools that are coming on board in January. We're extremely excited about that. In 1 year, we are thrilled to say that we have already seen savings against our projected costs. So from WPI's perspective, for instance, we budgeted our health insurance as if we were staying fully insured, only because we have never been self-insured here, not quite sure how things were going to go. So we budgeted as if we were staying fully insured. And we have already seen about, and we're just closing out the year, so it's somewhere between a 7 and 8% savings over what we had budgeted. I'm excited, our CFO is excited, our employees are excited, so far it's all been great. And from the employees' perspective, this has been completely seamless. So we worked together as a group, the 9 schools that took part in this, got together and said, let's come up with plan designs that will make it as seamless as possible for our current employees. So what we did is we worked with our health insurance providers, and we partnered up with them. And the schools, as Terry mentioned, that we're currently working with as partners, Harvard Pilgrim Healthcare and Tufts. And all of the schools, all 9 of the schools that jumped into EdHealth agreed that those were the tool schools that we used. And our biggest concern going into this was, were we going to be able to find plan designs that would satisfy 15,000 covered lives? Each school had their own plan designs, and we thought the hardest work was going to be coming up with plan designs that would satisfy everybody. Well, I'm happy to say that it took us 1 meeting, about 23 people sitting in a room, and that included the health insurers, and human resources people from each of the institutions. And after 1 day coming together, what we realized is there was much more similarity than we had ever imagined. So we established 8 plan designs that satisfied everybody. We use an administrator who helps us with the onboarding process and the administration. They were fabulous to help us with the setup at launch. They worked directly with the IT departments at each of the institutions to make this as smooth as possible. Great news is that after the first 6 months, so after December 31st, there was a surplus that was delivered to EdHealth, and this was in the first 6 months of a startup, which is fairly unheard of, very exciting. Our claims were managed below expected levels. I can tell you from the institution that I'm at, WPI, our claims had been running quite high for several years, and we were a little nervous about going from fully insured to self-insured, and I can tell you that it was a decision that I don't regret and am actually ecstatic about, because our claims finally turned, and instead of the profits going back to the fully insured carriers, the profits are now coming back to the institution and therefore going back to the employees. In addition, we're getting some fabulous reporting. So we get reporting not only for the institutions individually, but we're getting aggregate reporting so that we can look at all of the EdHealth members. And of course, we're HIPAA compliant and we're making sure that we're not violating any privacy. But we're able to use this information as we're going forward to design wellness programs, to manage diseases, and to design our health plans for the upcoming plan year. So some benefits, I think you've heard me mention some of them. Because we all came together as one group, we were able to negotiate lower fees with the third-party administrators. So Harvard Pilgrim and Tufts worked with us, and group buying power is very powerful. There are no hidden broker payments. Many of the schools who are members of EdHealth decided to maintain their relationship with their broker, WPI being one of them, but instead of having the broker payments hidden within the health insurance premiums, we're now paying them as consultants, and they're working as partners along with Spring and along with the TPAs. Again, being a larger group, we get better pricing, less volatility, and the profits come back to the institutions rather than going to the health insurance company. Being self-insured adds another benefit, and that is that we are avoiding some of the ACA taxes, and that can be up to 6% of premiums, which is very, very significant. So just to put it in perspective, as I mentioned, we're seeing some significant savings. When the feasibility study was first completed several years ago, the projection was that savings would be somewhere between 4 and 9%. I think with Obamacare and the additional taxes through ACA, we weren't quite sure how that was actually going to pan out, and it's actually turned out to be right on target, maybe even a little better. So one of the first schools to go in has already seen a 10% drop in expenses, and assuming that things continue the way that they are, they're going to see a 20% decrease in health insurance premiums, total cost, over the next 4 years. One of the other schools within EdHealth has already seen a 5.7% drop in expenses in the first year. So additional benefits, we've got the pooled experience, and Terry talked a bit about this. So we've got large numbers here. We are an institution that has approximately 700 employees that are on our health insurance plan, but we're now part of a group that has 15,000 covered lives. So that larger group means that our claims are more predictable, they're more credible, and it certainly is helping us to negotiate better pricing. The claims are also transparent. So what we're seeing is the actual cost that the TPA is going to charge us, the cost of the administrative fee. We're seeing any of the costs, and they're all visible to us. So what we're not having to see, and what we don't typically see, is the profit that goes back to an organization when you're fully insured. Again, those profits are coming back to us. So a captive, it is a nonprofit insurance company, very clear mission. It is owned by the participating members. So there is no additional owner. We own ourselves. We make the rules. We have direct access to the reinsurers. There's an incredible amount of transparency, and there is a potential for future dividends. So if the captive continues to be as successful as it has been, which we expect that it will, the initial schools that jumped in paid a significant amount of money just to get this kicked off, and I'll talk about that in just a moment. And that money will have the potential to go back to those early adopters. So how does EdHealth work? So when we first started this, we created a sponsoring organization, and the name of the group is SEV1, and it stands for the Collaborative Educational Ventures of New England. And it was launched in March 11, and this is really the umbrella organization. And this organization was established to look at how we could cut costs in higher education, not specifically healthcare, but cut costs across the board. The very first initiative was EdHealth. And in order to get this started, 23 institutions joined SEV1 and expressed interest in this. The 23 members provided nearly $1.5 million to fund the initial development of EdHealth. And now here we are, 4 years later, and EdHealth is now financially independent of SEV1. It is up and running, and SEV1 is actually working on several other initiatives to reduce expenses at institutions of higher education. So EdHealth, as mentioned earlier, is EdHealth was formed as an LLC on July 12th of 2012, and the purpose of it was to design and coordinate self-funded health insurance for institutions of higher education in New England. We did start in Massachusetts. However, we are working with several institutions that are outside of Massachusetts, yet still within New England. And in order to commit to EdHealth, we are asking for a 3-year commitment. And what that does is it creates a stable risk base and allows for underwriters to look at things on a longer term. EdHealth LLC is the parent company that oversees the overall program, and that includes a group of self-insured plans, so that's each of the institutions, and then there's a pooled stop-loss insurance program, and that's administered by the Vermont Reciprocal Captive that Terry was talking about. So we did choose to domicile the captive in Vermont, and that was because we are a New England-based company. So here's a visual so that you can see how this all works. So at the top is SEB 1, so this is the sponsoring entity. And then there's the Massachusetts LLC. Underneath the Massachusetts LLC is the LLC out of Vermont. There is the Vermont Reciprocal. We do have the EdHealth management team. And then we have the self-insured plan operations. And here's the program structure. And this goes back to the benefits. We have buying power. We have one central point of contact for billing, employee interface, employer data. We have full control. We get to determine what the plan designs look like. We get to determine what our self-insured rate is. We get to determine all of this as a group. There's full financial transparency. There are no hidden costs. And the flexibility is amazing. Again, we get to determine our own plans. We have all agreed on one plan year. Coming into this, there were several different plan years. We've all agreed on one plan year, which is going to be a calendar year, and that will begin on January 1st of 2015. Here are the 9 initial members of EdHealth as of January 1, 2014. As I mentioned, we have 3 more joining on January 1 of 15, at least 3 more. And at this point, I am going to turn it back to John.
Thank you very much, Tracy. I appreciate you covering that in some excellent detail. I just mentioned here the Healthy U Disease Management Program. That's one of the developments that took place before the EdHealth program in terms of looking at ways of getting the employee population amongst the colleges with better wellness and health. This has been established since 2010, and this has now been rolled into the EdHealth program as a way of starting to attack the basic claims cost base that we're experiencing. And this is an opportunity as the group develops to refine that and improve it for the particular group. The way in which EdHealth develops in the future is obviously, as Tracy said, taking additional schools from Massachusetts or other states to that effectively spreads operating costs and enables risks to be managed more effectively. Providing coverage for other risks, the basic structure allows you to look at additional risks like life, disability, retiree medical, and even pension cost exposure uses the same sort of structure for managing those risks. We are going to look at expanding coverage to retirees, effectively to overseas employees and to students as the other developments, either through SEB 1 or through EdHealth, expanding, as I say, the Healthy U program, and refining as we go forward the detailed claims and cost analysis and benchmarking to participating schools so that they can take local action to improve their situation with regard to employee health. And we also have the opportunity to partner with health providers and look at on-campus health facilities to really look at other ways of creating a more efficient health experience for the group. So overall, EdHealth and this type of structure can effectively grow to become a true population risk management vehicle for its owners, and we're very excited about the possibilities going forward. So just as a background, how can you find out more about this? Obviously, Spring does a lot of this work and is very familiar with these types of programs and can talk to you about how your particular group or individual college could fit into the program. We can then develop a detailed diagnosis from a captive point of view, looking to see whether this or a similar type of structure would work for you. And then, obviously, we are, as we've demonstrated with EdHealth, able to design and then implement the program in a very seamless way. And we've been doing this for a long time, and we're able to take advantage of a lot of the relationships we've built with regulators and the Department of Labor and other groups to make this a very smooth experience. So at this point, we do have one question that's come up. Somebody's asked, how long does it take to put a captive together? Basically, it depends on the group and within their structure and priorities, how fast they want to move. We have had clients where we've put a captive together within 6 months from initial discussions through to implementation. That's quite fast. Typically, it would take a year or so. EdHealth took somewhat longer because we were putting these other structures together and getting the involvement of particularly some of the consortia. But a year would be perfectly adequate to put these together and produce an efficient program. Let me just check if there's any other questions. No, I don't see any other questions. So what I will do now is to talk to you about part 2 of this program. We've focused really on the broad-based benefits and structure of how captives work. There's a lot of underlying financial structure and risk management that is put into these programs in order to make them work and to protect the participants and meet the regulatory requirements. So in part 2 of this program, which we're going to schedule for early September, we will put the details at that level about the financial information in a program similar to this one. And if you'd like any further information on that, then please contact myself or Terry Weber at Spring. Other than that, I'd just like to thank you very much for participating, and we look forward to talking to you soon. Thank you.